Now? Yeah. So this is a 9-year-old, 20 kilogram, with a tetralogy of below transannular patch native tissue patient who fit the criteria for a valve replacement. So and that's his echo, nice narrow RVOT. So from procedure standpoint, you know, like one of those straightforward ones, you know, it's not dilated, it should be quick and easy. And this is when you fell into trouble. I'm putting this view just to show you the tricuspid valve because that's related to what you will see later. So there's a trivial TR there. So we did the standard pre-procedure view, looking at the coronaries, sizing the RVOT at the same time. Everything is going smoothly until when we passed the pre-stent. As you can see, for the sake of time, I'm not going to show all the pictures that led to this, but the balloon slipped, or the stent slipped back, or the balloon slipped forward, actually. So in attempts to try to recapture that, remember Frank was talking yesterday about how one thing leads to the other, you know, one bad decision leads to the other. So we end up here. The balloon, the stent is almost completely exposed, and it's posterior, and it's obviously mostly in the RV. Now, this is a covered stent, by the way. This is how it looks on lateral. So we're really pretty much hanging right there at the RVOT muscle. So we contemplated what to do. Now, if you notice, we tried to put some wires and try to see if we can push it forward. So this is like 2 hours into the procedure. Now we thought about dilating the tip of the balloon and use it as a dilator and try to push the stent through the RVOT. Maybe that will work. So that only flange the stent open more and cause it to be wedged even more in the RVOT. You can see the muscle here. It's hanging right there at the junction of the annulus. This is how it looks AP. So at this point, we thought, well, let's try to put another balloon with, putting a lot of force, stiff wires, and try to put another balloon there where you can see the open struts and try to close it or make it amenable to be pushed through. That didn't work out very well because obviously it's on a different level when you look at it in lateral. We tried pushing it, also supporting it with the sheath from below, and that's the cause of this loop that you see. So after doing all that, and we decided to go ahead and open the stent. Hopefully it will catch on the RVOT and stay in place. Obviously it didn't. So now we have this covered RV stent in the covered stent in the RV. But you do have a coaxial system through it. So what do you do here? Obviously, the first option is to go to surgery. Of course, it is a covered stent, so it's not just even like a regular stent. You have to worry about the tricuspid flow, the outflow flow, everything. However, we thought that we need to try to save it. So we thought of putting an anchor in it through another stent into the RV. So with the support of the sheath, we supported the stent from inferior, and we put another stent through it into the RV. And that went well, actually. We opened it up, and okay, it's a little bit slow, so that kind of was inflated nicely to the end, as you can see. On lateral, nicely done. So we were not too unsatisfied with this result. We did an angio here, and you can see that it's actually not in a bad position. It's not as as it looks. It's not as bad as it looks. When you look at lateral, there is some inflow, and let me show you the infection. So 2 months later, I'll show you the echo when the patient came 2 months later. And this is the stent here, and we see that the inflow, outflow is pretty much preserved, and there's not much TR, so the tricuspid valve luckily was not affected. So at that time, we were encouraged to go ahead and complete the procedure and put the Embolized valve through. And that's what we did here. Of course, we did that loop to avoid pushing or putting a lot of tension on the edges of the stent. So that way you can kind of have the valve go centrally as much as possible. Through the relaxation and pulling of the wire, you can advance it in a way centrally. So that's also important. So we put the valve obviously higher than normal due to the position of the pre-stent. Inflated the valve, everything went nicely, smoothly. This is the post implantation injection. Okay, so no regurgitation. As you can see, there's an LPA stenosis there that we will address later. And lateral doesn't look as bad. That's why we didn't do anything for it before. And that's the echo, nice functioning valve. And most importantly, you can look at the tricuspid valve. The inflow looks really nice, not really affected. So I think overall, it looked okay. It looks good. Not angiographically, it may not look as nice as we like it to be. But two lessons that I learned from this procedure is always try, because me and colleague were working, and one of the of course the choices was just to pull the whole system out and reposition, reclamp, crimp the stent and do everything all over again. Unfortunately, ego won over wisdom, which I think should never happen in the cath lab. And I think that's one of the things that make you or lead you to go into bad decision one after the other when you run into complications. So that was the important lesson for me. The other lesson that if that happened, try to stay in the cath lab as much as it takes to try to fix something that a complication or something wrong that happened to the best possible situation. Thank you.